although Nick told us that it's difficult to expect a discrete MPN or MPD entity in these overlapping pathologies, there might be one. And I would dare to say this is probably the 5q minus syndrome as we know it. How do I move this? Hit a click. All right, I realized, yeah. So this is the, okay. This disorder that is marked clinically by refractory anemia cytogenetically shows the deletion of the long arm of the chromosome 5, and this is the interstitial deletion. So the telomeric part is retained and is moved up to the centromeric region. By the definition of the World Health Organization, these patients should have isolated deletion 5q. It's allowed to have one more low risk, so-called low risk aberration, like for instance, loss of sex chromosome or 20q deletion. They should have less than 5% blasts in the marrow, and they of course have typical bone marrow morphology. In peripheral blood, there is the refractory anemia, and platelet counts can be increased. This is the karyotype of a patient 12 years ago. She's still alive and in treatment. So the morphology is, where is the arrow? All right. Yes, I found it. So the morphology is typical. It's erythroid hypoplasia. The megakaryocytes are usually monolobulated or hypolobulated. The blood counts anemia, microcytic, modest leukopenia, and platelets, as I said, could be normal or increased. The other typical features are that it's usually females who we see as patients, and they could be of older age. We don't know why. I mean, they are the females. Refractory anemia, peripheral blood, good prognosis. The median survival is usually longer than 10 years, and it has a low rate of transformation to acute leukemia. Well, how consistent these clinical features are, as everything else in biology, they are not completely consistent, and the studies by Jagonidis reported several times doing the survey on his patients have shown that the hypocellular marrow is present in 40%, there might be hypoplastic erythroid lineages in 50%, dysplastic erythrocytes and granulocytes might not be that affected. But consistent is that all the megakaryocytes are monolobulated or hypolobulated. What would be the questions that we would put for the 5q minus syndrome today? Well, the first certainly challenging is what's in this tail of long arm of in the long arm of the chromosome 5 genetically? Is it causing the disease? What explains the hematological features of this syndrome? And why is lenalidomide so effective in this disorder? This is actually a drug that's, of course, derivative of thalidomide and has a broad activity in terms of controlling angiogenesis. It's anti-inflammatory and it's immunoregulatory agent, but it's very, very effective properly in 5q minus syndrome. Let me take you briefly through this chronological chart of 5q minus syndrome story. It started in 1974 with Herman van den Berge from Leuven, who described this as a sole cytogenetic abnormality in patients, in a cohort of patients with 5q with mild dysplasia and refractory anemia. And he noted that this is the first single genetic abnormality for hematopoietic neoplasm after the discovery of Philadelphia chromosome, which occurred 14 years ago. A year after, George Sokal published the blood paper and first time used the name, the syndrome, 5q minus syndrome. Then nothing was more or less happening until 90s when people are starting to delineate the deleted region on the chromosome 5, and that the efforts to positionally clone the genes in the region were in due course, were starting. Then the explosion of novel knowledge occurred and is still occurring today from the late 2000s. But Alan List first reported the successful use of lenalidomide in 5q- syndrome and in deletion 5 MDSs. And today we see a tremendous advancement in knowing and introducing some new notions in the pathology of 5q-, as is the haploinsufficiency, which we'll be telling you about in a minute. Then the role of the ribosomes as organelle in the cytoplasm. Then the significance of mutations discovered by NGS, as Nick was also telling us. Then there is the importance of microenvironment and the osteal niche for the clonal survival of this genetically changed cells. The microRNAs are important, looks like, for some of the clinical features, as I will tell you. And of course, although we knew that this is the stem cell disorders, only last year Wall and Arls reported that driver mutations are indeed occurring in the early multipotent hematopoietic stem cell. So on the anatomy of this lesion on long arm of chromosome 5, the deletion is actually usually quite a large one, and it's interstitial. And I have marked here the areas that are affected usually by these deletions. The larger the deletion, clinically, the worse the prognosis, as we know. Then the deletion 9q also occurs in a complex of other karyotypic abnormalities frequently associated with transformations in acute leukemia. There are two regions that are called so-called common or critical deleted regions. One that is upstream is usually deleted in acute myeloid or transformed MDSs, but the second one seems to describe, if I may say, the true 5q- syndrome. It entails the genes that we shall see in a second critically deregulated on this chromosome. The main question was in the pathology and pathobiology and our efforts to try to understand 5q- syndrome and the deletions of the long arm of the chromosome, what is the basic genetic molecular abnormality that is the consequence of the deletion. The hypothesis that was alive in the late 90s was that it is probably the case of that has been described by Knudsen in a so-called Knudsen model of inactivation of the tumor suppressor gene, in which you have to have both alleles of the gene deactivated to get a phenotype. In the case of 5q-, this would be, of course, the deletion, which where some of the genes are lost on the deleted part of the DNA, and then by this hypothesis, the acquired mutation should occur on the retained allele. This is something like something like this works in the retinoblastoma pathology, for instance. But to our surprise, it wasn't possible to find a mutation in a gene, in a single gene in this deleted region on the retained alleles. And what we know today, it's the mechanism of haploinsufficiency that is responsible for the pathogenetic and the biology of the disorder, and the haploinsufficiency of the genes leads to reduced expression of the candidate genes in the region. There are approximately 40, but some of them, the names of who you saw a bit earlier, are critical, seems like. The group of Andrea Pelagatti and Boltwood and Jacqueline Boltwood did this experiment looking at the expression by expression profiling, as also Nick showed us, for the candidate genes in the deleted region, and they are all decreased in the expression appropriately for the phenomenon of haploinsufficiency. Here I have given just a few names of the one that you will see now seems to be very important in the pathogenesis of 5q- and for the response to the lenalidomide. The first gene that has been shown to a concept of proof of haploinsufficiency in 5q- was the ribosomal protein 14 that is essential for assembly of ribosomal subunits, and in a very nice work by Benjamin Ebert and published in Nature, by using RNA interference and gene silencing for each of the 40 genes in the critical region, he has seen that exactly RPS 14 was affected most strongly by this haplodeficiency, and the experiments have shown that its haploinsufficiency leads to MDM2 sequestration. Through this, the p53 is stabilized, and erythroid cell death occurs, which leads to anemia as the main consequence in the phenotype of the 5q- syndrome. From the work of gene expression profilings, as we have seen in 2 slides before, the genes from the critical region that are downregulated on long arm of the 5, the genes that are phosphine proteases, then the significant one, important one, casein kinase, and these all genes here put on the white background in the scheme of the VNT signaling model involved in the regulation of beta-catenin, and they activate the VNT response genes. I have left also the sonic hedgehog pathway because we should probably hear about its importance in designing new drugs. It also interacts in controlling beta-catenin, so I left it here too. There are other pathways deregulated that include protein ubiquination, Huntington disease, even estrogen receptor signaling, and cell cycle checkpoint regulations. In a work that's been conducted by Andrea Pelagatti, and we collaborated in this one, has shown that the casein kinase, first of all, upregulates the genes that are involved in VNT beta-catenin. And also, this was the first gene where the single point mutations are described in the exon 3 and 4 of the gene. In this particular work, a novel mutation has been discovered. This is the missense mutation. It's not the loss of function mutation. However, interesting is that one of the 3 patients that are 5q- and were in this cohort of patients and mutated is resistant to lenalidomide. So it might have something to do with this mutation, with the resistance, well, we don't know yet. The lenalidomide, as mentioned before, was described as an effective drug in 5q- and DIL5Q MDS is by Alan List, and been later confirmed by many others, and we are today using this drug in the clinic for the treatment of 5q- MDS because it induces a significant erythroid response in patients. The patients that are transfusion dependent become independent. In 2/3 of them, there is a significant increase of hemoglobin in patients. And of course, what's very impressive that complete cytogenetic responses or remissions have been described in about 45%. However, half of the patients will develop resistance after 2 to 3 years of therapy. The lenalidomide is the derivative of thalidomide, as we said. It modulates ligand-induced responses, including angiogenesis, inflammation, cell adhesion, and the immune response, as thalidomide does too. On its activity, it seems that haploinsufficiency of casein kinase and other protein phosphatases like PPR2 regulatory subunit or cyclin-dependent kinase 25 make this cell susceptible to lenalidomide. It induces ubiquitination and degradation of casein kinase. It also, interestingly shown by Andrea some years ago on CD30 positive cells in vitro culture treated with lenalidomide. It increases highly one of the molecules that are, or genes or molecules that are encoded by the gene from the critical region. This is the SPARC or osteonectin gene, and we are not fully aware what does that mean. This is the anti-adhesion molecule, anti-proliferative, and anti-angiogenic molecule. The microenvironment today attracts a lot of attention, and I'm certain that we shall be hearing about it in the forthcoming presentations by certainly many speakers. It provides the safe haven for the clonal cells, and we know today, this is a very simplified sketch. There is the complex interplay between the hematopoietic stem cells, either leukemic or MDS ones, with the osteogenic cells that encompass endosteal niche. There is also the endothelial niche and mesenchymal niche. And the same very complex interplay has been active also in myeloproliferative disorders, as has been recently shown by a San Francisco group. Many years ago, doing a little study on 100 and something MDS patients of all FAB profiles, we were able to morphometrically show that having osteoblasts on the trabecular in the MDS is not the bad sign. It actually provides a survival advantage, seems to us, compared to disorders that had suppressed osteoblastic cells on the surfaces. Recently, it has been shown that by knocking down dicer, a microRNA regulating molecule in the osteoblast, one can cause MDS phenotype in an animal, and that also in that introducing a healthy hematopoietic cells in such an animal, they develop MDS. Lenalidomide exerts its activity also in this context. It's a growth arrest modulating agent in this setting. It modulates adhesion, decreases angiogenesis, which is important, of course, suppresses cytokines like TNF-alpha and interleukin-6. And before the end, I tried to summarize the effect of haploinsufficiency of the critical genes on 5q on the activation of many other genes and molecules that are responsible for the 5q minus phenotype. For instance, microRNA 145 haploinsufficiency leads to upregulation of the genes like tall interleukin receptor antagonist protein, and it's been probably responsible for increased platelets. Some of the myelodysplastic syndrome might have also JAK2 mutated, but not a large proportion of them. But the main contribution to thrombocytosis is ascribed to this phenomenon. MicroRNA 146 haploinsufficiency leads to activation of many intragenic pathways, as has been recently described, in the end ending with upregulation of P protein, P62 molecule. And for this protease haploinsufficient genes, it's the ultimate consequence is upregulation of P53, and which is responsible for the suppression of erythropoiesis and anemia in peripheral blood. And lenalidomide controls, as we have seen earlier, this part of this complex network of pathologic events. Also, it looks as if these cells have a specific immunophenotype which can be confirmed by flow cytometry, as has been described 2 months ago. So it would be useful to put it in the practice and see if it can help us with any of the diagnostic aspects of the disease or prognostic aspects of the disease. Well, for the end, worth noticing about 5q minus, I would say that it's certainly a unique hematopoietic stem neoplasm and myeloid neoplasm. It could serve as a model disease in many ways for the research on other MDSs or myeloproliferative disorders. Perhaps it has a stable genetic lesion. It has a low frequency of copy number variation than uniparental disomies. Has, however, a spectrum of molecular pathogenetic mechanisms, as we have seen, that promote neoplastic clone and cause phenotype changes. And there is a clone-targeted therapy practically in terms of lenalidomide that whose activity mechanism have been reasonably elucidated, but certainly there is more to know. So I would expect the researchers to focus on why do the breaks on long arm of 5 occur and cause the breaks in DNA, and many such efforts have been in due course for lymphoid malignancies where high recombination rates are occurring in the immunoglobulin genes, for instance. So what causes the breaks? Are there more mutations to be found in the critical deleted region genes, like as we have seen in casein kinase gene, by using these powerful technologies of next generation sequencing? Of course, the question is, what do they mean? And for instance, attractive question is, would the knowledge that we gathered on 5q influence the research on 20q, for instance, which is another unanswered arena of relatively good prognostic refractory anemia MDSs? And it is going to be exciting to see what will be the developments in novel therapy, like introducing translation enhancers or more p53 inhibitors like Senersen or P2 inhibitors. And let me please thank for the support and collaboration of my colleagues in Zagreb and Croatia that are gathered under the Croatian network of national hematologists, CROHEM, my colleagues from the University Hospital Dubrava and cytogeneticists in the hospital center Zagreb. Then there is the collaboration, long-lasting collaboration with the colleagues in the Nuffield Department of Clinical Laboratory Science in Oxford, led by Andrea and Jackie Boltwood, and there is a fruitful collaboration with colleagues in Vienna, Peter Valent and Wolfgang Speer.